the chances he'll be hospitalized are going to be higher. The CDC-funded state programs and tracking have been cut, leaving schools less prepared to deal with asthma. Every dollar spent on asthma control saves an average of $71. The program is now gone. If you have teenagers and are worried about them vaping or experimenting with other substances, you have even more to worry about now. A few years ago, when teens around the country were hospitalized for lung damage after vaping with contaminated cartridges, the outbreak was promptly curtailed because CDC's emergency response surged, sounding the alarm and helping states around the country. But the staff with needed expertise in this area have been cut. If you're a business executive with distributed supply lines or an oil executive visiting Angola or Nigeria, your safety and the stability that your business needs are now at risk. In the past, CDC enabled early responses to Marburg and Ebola and trained staff in country as a first line of defense. CDC's global health leadership and staff have already been cut, along with programs that stood ready to protect us from global threats. If your grandmother was recently exposed to hepatitis when she visited a pain clinic in Florida, she won't be able to get the specialized screening tests she needs because the CDC lab that was going to aid Florida in this outbreak already got shut down. Problems don't go away or magically disappear when we stop tracking them. They just become much harder to deal with once they get so big that we can't ignore them anymore. These are just a few examples of far-reaching impacts. We may not feel them today or even tomorrow, but we are all at greater risk from the seemingly indiscriminate cuts to the nation's core public health capacity. And the effects go beyond the reduction in forces and budget cuts at CDC. The restrictions on CDC experts' communication at a time of excruciatingly confusing messaging from top HHS leadership is making it harder to control measles outbreaks and threatening a resurgence of other vaccine-preventable diseases. The people who work in public health at CDC and around the country are strong, skilled, and incredibly resilient. They will tell you it's not about them. They share the values of our partners at Rotary International who believe in service above self. They're worried about the deadly and costly impacts on the public they serve. People in public health are worried, but right now, everyone should be worried. Thank you.
Dr. Shuka, thank you. Simple message, no one to call. Really pretty astonishing. Thank you. Ms. Trina Dutta, thank you. And you were Substance Abuse and Mental Health Services Administration. SAMHSA provided enormously good help to the state of Vermont, so thank you. Thanks. Well, thank you.
Good afternoon, Senator Welch. My name is Trina Dutta, and I've spent a total of 12 years working at SAMHSA since 2006. Most recently as the agency's chief of staff. I'm honored to join you today to reflect on the extraordinary work conducted by SAMHSA and explain how changes can and will impact the health and wellness of our communities. Over the past decade, SAMHSA has undergone positive transformational reform, bipartisan investments, including the 21st Century Cures Act in 2016, the Support Act in 2018, and the Bipartisan Safer Communities Act in 2022, gave SAMHSA the resources it needed to respond to unprecedented behavioral health epidemics. Congress and the American people took the behavioral health needs of our nation seriously, and thankfully we are seeing the fruits of this labor. CDC just released data estimating that overdose deaths in the United States fell by nearly 27% last year, from 110,000 in 2023 to 80,000 in 2024. This remarkable achievement is a direct result of federal investments in focused efforts on opioid use prevention, overdose reversal medications, expanded access to medications for opioid use disorder, and peer support. We can also be proud of the impact these investments have had to reduce suicide amongst specific groups. Per the CDC, again, annual suicide deaths for youth under 18 dropped by over 12% from 2018 to 2023. And for adults aged 50 to 65, the group most likely to die by suicide, annual suicide deaths decreased by more than 8%. Since SAMHSA launched the 988 Lifeline in July of 2022, over 14.5 million calls, texts, and chats have been answered and routed to trained crisis counselors. And the federal government has invested heavily in crisis hotline infrastructure, mobile crisis teams, and other interventions to ensure that everyone has someone to contact, someone to respond, and a safe place for help. To sustain and continue these hard-won improvements and support states and local communities, the focus, commitment, and pace of activity must be maintained, if not magnified. Unfortunately, SAMHSA has lost almost 40% of its staff since January, is facing a budget cut of over $1 billion, and faces uncertainty given plans to end the agency as we know it. SAMHSA has always been the little engine that could and is nationally recognized as a source of reliable, evidence-based information on behavioral health interventions. This dramatic loss of institutional knowledge and subject matter expertise will be felt by states and communities who rely on SAMHSA's policy and programmatic guidance to promote mental health, prevent substance misuse, and provide treatments and supports that foster recovery. For example, all 17 people running the country's only nationwide survey on substance use and mental health were RIF'd in April. For over 50 years, the National Survey on Drug Use and Health has tracked these issues across the United States. This sudden loss of expertise will undermine HHS's ability to monitor substance use and mental health trends, to estimate the need for treatment, and to inform public health policy. Proposed cuts of more than $1 billion threaten to stymie progress just as we're seeing real measurable results. Such cuts to SAMHSA's discretionary grant portfolio will impact on-the-ground programs that serve millions of Americans. SAMHSA's discretionary grants serve as a powerful innovation engine, which have allowed the government to scale up interventions like coordinated specialty care for first episode psychosis, peer support services, and crisis care. Cuts to programs like those that support pregnant and postpartum women with substance use disorder, that foster mental health awareness training, and that promote the wellness of young children would force states to use their block grant dollars to pick up the slack. And at a time when looming Medicaid cuts will put even more pressure on those block grants, communities will be left in a precarious position as they address their mental health and substance use disorder needs. While clinical and system-level integration of behavioral and physical health care is crucial, folding SAMHSA, its portfolio, and its personnel into the larger AHA structure risks a devastating loss of focus on behavioral health within HHS and this administration. It is difficult to see how this proposed change supports a strategic behavioral health agenda, instead threatening to endanger the administration's stated commitment to creating a healthier America. On a personal note, since beginning my career at SAMHSA almost 20 years ago, I have been profoundly inspired and motivated by the commitment of my SAMHSA colleagues to ensuring that people with, affected by, or at risk for mental health and substance use conditions receive care, achieve well-being, and thrive. SAMHSA staff and grantees alike work tirelessly on behalf of a population that is often plagued by poverty, violence, comorbid physical illness, homelessness, and stigma. But they do the work with the hope and knowledge that these individuals can improve their health and wellness, live a self-directed life, and strive to reach their full potential. It is in this spirit that I approach you today, in hopes that the life-saving work SAMHSA does on behalf of our country will be preserved and championed. Thank you for your time today.
No, thank you. I mean, it's astonishing to me where the numbers are going in the right direction, that we're now defunding all the programs that, with patients, have produced the results. Really, we'll come back to that. Thank you. Dr. Sean Bruna, Agency for Healthcare Research and Quality. Dr. Bruna, thank you for being with us.
Thank you for having me. Most people have likely never heard of the Agency for Healthcare Research and Quality, or AHRQ, but it plays a crucial role in our healthcare systems. Congress charged the Agency for Healthcare Research and Quality with improving healthcare by working in partnership with all entities in the healthcare system, states, healthcare systems, hospitals, clinics, healthcare professionals, HHS divisions, and all of us as patients. When we visit a doctor, we're part of the AHRQ partnership that is working to improve healthcare. AHRQ is one of 4 science agencies within HHS and serves as an applied science agency that funds the research necessary to improve the quality of care delivered to the American people. The research AHRQ funds does not sit on a shelf. It is new and actionable knowledge generated in healthcare settings across urban and rural communities. It helps us answer questions such as what treatments work best, how can we improve patient safety, and what tools do healthcare providers need to deliver better care. As Dr. Robert Valdez, former AHRQ director, reminds us, quote, making medical progress requires 3 intertwining strands of scientific inquiry: biomedical, technology assessment, and applied health services research. The latter 2 strands were housed and pursued within AHRQ, end quote. The administration's recent reductions in force have shut down most of AHRQ's work and eliminated at least 2/3 of its staff. These positions were not redundant. They supported current and future generations of health services researchers. These cuts have led to the cancellation of healthcare evidence reviews, the discontinuation of the development of clinical improvement tools and guides that medical professionals use to enhance clinical care, and the termination of research grants, and the elimination of all programs that train the next generation of researchers in our country's health services. The cuts have impacted innovative work, such as the AHRQ Long COVID Care Network Coordinating Grant. This grant enabled long COVID clinics to share new healthcare evidence and best practices with thousands of patients nationwide. In addition to AHRQ's appropriated funding, it receives mandatory funding from the Patient-Centered Outcomes Research Trust Fund, which supports research that helps patients and providers make real-world decisions based on evidence. Personnel and projects funded by the fund have been eliminated. These cuts limit our ability to generate the science that underpins patient-centered care. One especially significant program initiated by AHRQ that was terminated is the State Healthcare Extension Service. State health plans and providers have emphasized that collaboration is crucial to achieving successful healthcare outcomes. This extension service initiative supported states in improving their Medicaid-financed healthcare systems by helping local providers, payers, and patients collaborate for better outcomes, lower costs, and a better healthcare experience. With its law, states have fewer tools to rapidly and efficiently share and promote improvements to their healthcare systems. AHRQ also provided critical scientific advice and assistance to other federal agencies. AHRQ supplied scientific evidence to CMS, informing Medicare coverage decisions, to the FDA for tobacco regulation and post-decisional surveillance of drugs and devices. It identified gaps in biomedical evidence, which informed the NIH's research agenda setting and helped translate biomedical research into clinical practice guidelines.
I got 2.
The proposed reorganization would essentially eliminate AHRQ, folding just some of its programs and staff into the Office of the Secretary, stripping away the specialized expertise that made AHRQ effective. Key AHRQ data systems used to improve healthcare, such as the consumer assessment of healthcare providers and systems surveys, the healthcare cost and utilization project databases, and the medical expenditure panel survey, face disruption or discontinuation altogether. These systems provide the data we need to understand how people in America experience healthcare, what they pay, and where improvements are needed. Without these tools, we put our nation's healthcare improvement data at risk of manipulation and exploitation, potentially leading to the generation of misinformation. Dismantling AHRQ will have nationwide consequences. It weakens evidence-based care. It hinders healthcare from addressing emerging threats and dismantles grant programs that support current research and the training of future researchers. It eliminates mandatory funding from the Patient-Centered Outcomes Research Trust Fund, requiring an Affordable Care Act amendment, and strips vital tools from state and local health systems working to improve care. In short, the two applied science strands that facilitate medical progress and aid in implementing scientific innovations in our healthcare systems would be lost. Thank you for your time.
Thank you very much, and I want to welcome Senator Angela Alsobrooks of Maryland and invite her to make some comments. And thank you so much, Senator.
Thank you so much, Senator Welch. And also, I saw her leaving, so also want to thank Senator Baldwin for putting together these spotlight events. I certainly want to also thank our witnesses who have taken time to be here today as well. Senate Democrats, as you all have probably now heard, are working in lockstep to defend against the cuts to the department, attacks on public servants, and cuts to critical biomedical research and human services. And I'd like to reiterate my gratitude to everyone for coming here today, for sharing your time with us, and helping us to cast a light on this administration's absolutely disastrous policies. I want to be very clear about something. What is happening at the Department of Health and Human Services is not normal. But don't take my word for it. The leaders who have joined us today, both political appointees and career civil servants, have served this country admirably. They can speak firsthand to what actions by the administration and Secretary Kennedy, they can talk about what they're doing inside the building to disrupt services, slash research, and undermine HHS programs. Secretary Kennedy could not answer very basic questions about his agency last week. I was there during a HELP committee's budget hearing, and rather he inserted that not a single scientist had been fired as a part of the administration's reorganization and reduction in force. We understand this to be an outright lie. But that wasn't the only lie that Secretary Kennedy spread last week. Chairman Cassidy had to come back in the hearing room and fact-check him after he claimed that no vaccines besides the COVID vaccine had been evaluated against placebo. Secretary Kennedy continued to cast doubt about the safety and efficacy of vaccines and sow doubt with the American people. I questioned Secretary Kennedy as well about cuts that imperil NIH's Safe Sleep program, the CDC's Division of Reproductive Health, and programs that serve individuals with disabilities. I had questions about his cuts to NIOSH, HIV research, and maternal health. One thing was clear. Secretary Kennedy does not even understand what the programs are that he has cut or the civil servants that he's terminated. He has no idea what they do. That's why I'm so glad that we have our subject matter experts who are here today to share exactly what is at risk and how we can fight back to preserve the institutions and programs that Americans across our country count on.
Thank you. Thank you very much. Professor Allison Barkoff. Professor Barkoff, the Administration for Community Living. Thank you so much for being here.
Thank you. Good afternoon. I'm Allison Barkoff, and I served in the role of Assistant Secretary for Aging and Administrator at the Administration for Community Living, or ACL, under President Biden, and I'm now a professor at George Washington University. Thank you for the opportunity to share the devastating impact that the Trump administration's dismantling of ACL is having on the tens of millions of older adults, people with disabilities, and caregivers who rely on its programs to live in their own homes and communities rather than in nursing homes and other institutions. ACL provides critical life-sustaining supports, including Meals on Wheels, delivering over 260 million meals and connection each year to homebound older adults. Support to more than 1.5 million family caregivers annually. Help transitioning over 250,000 people to their own homes from a hospital or nursing home stay, and assistance to over 50,000 disabled people and their families in accessing healthcare, assistive technology, and other services. ACL's programs are cost-effective. 1 year of home-delivered meals costs less than 1 day in a hospital and 10 days in a nursing home. And they save hundreds of millions of dollars annually to Medicaid and Medicare by preventing unnecessary hospital and nursing home admissions. While ACL is a small agency, its programs have huge reach. 1 in 5 older adults, 11 million Americans, rely on ACL's aging programs. 1 in 4 Americans, or 70 million people, have a disability, with nearly a quarter benefiting from ACL's programs. And the need for ACL and its programs is increasing exponentially, with over 11,000 people turning 60 every single day, and a growing population of disabled people living longer. That is why it is astounding that the Trump administration is dismantling ACL and proposing to eliminate dozens of its essential programs. ACL is being eliminated in the reorganization, and its quote-unquote critical programs scattered among 3 other HHS agencies. The very efficiencies that led to the creation of ACL, coordination of programs at federal, state, and local levels, will be gone. The Trump administration has fired nearly half of ACL's staff, including its entire budget, grants, policy, evaluation, and regional staff, making it nearly impossible for the remaining staff to timely fund and implement ACL's programs. The White House, in its leaked April OMB passback, is proposing to completely eliminate nearly 20 major aging and disability programs. That includes all of the programs that protect older adults and disabled people from abuse and neglect, despite promises to protect vulnerable populations. It includes most of the evidence-based healthy aging programs, despite claiming the reorganization is about focusing on disease prevention. And it includes eliminating all of the programs that support people with developmental disabilities, including autism, programs under a law championed by Secretary Kennedy's father and uncle, and despite Secretary Kennedy identifying autism as a priority. Due to funding delays and uncertainty about the future of programs, people are literally losing critical services they rely upon daily to stay in their own homes and communities. The aging and disability networks are small and underfunded, and they can only endure funding delays for short periods, many as little as 2 weeks before services are impacted. And that is exactly what happened at HHS as services were delayed this spring, as funds passed by you as part of the continuing resolution did not go out. Some aging providers began declining new referrals and had to put people on waiting lists, including for meals. Some protection and advocacy agencies had to stop intake and limit monitoring institutions for abuse and neglect. And most agencies had to divert precious resources away from providing services to emergency contingency planning. And it is only because incredibly strong stakeholder advocacy, media, and oversight from you that HHS temporarily brought back staff and finally, over the last several days, began dispersing formula grant funding from the continuing resolution. Other grants funded in the CR are still delayed, and staff will be gone by early June, unable to get funding out. The harms from dismantling ACL and eliminating programs is compounded by what's happening literally on the other side of the Capitol as we speak. Efforts by Republicans in Congress to decimate Medicaid, threatening the additional community services that older adults and disabled people rely on. And all of this together will mean rollbacks on decades of progress. Older adults forced into understaffed nursing homes rather than able to age in place, and disabled people shuttered away from society, taking us back to the days of Willowbrook. The ACL programs wrap around and serve as the glue and coordination that increase the efficiency of Medicaid, Medicare, Social Security, and other programs. Community living simply is not possible without ACL and its critical programs. Thank you for all of your efforts to stop this devastation and to support older adults and disabled people. Thank you.
Thank you very much. And now we have Dr. Jeremy Berg. Dr. Berg, thank you for your service as Director of the National Institute of General Medical Services within NIH. Welcome.
Thank you very much, Senator Welch. The National Institutes of Health is the largest and most accomplished biomedical research engine in the world. I had the privilege of serving as the director of one of the 27 institutes and centers at NIH, starting in 2003 under President George W. Bush and extending until 2011 under President Obama. The National Institute of General Medical Sciences, or NIGMS, is the institute most focused on basic or fundamental sciences, but also covers clinical areas such as anesthesiology, burn and trauma, and wound healing research. Working with the outstanding staff at NIGMS and across NIH in partnership with scientists around our country was the best job I ever had. Wow. Broad terminations by a variety of mechanisms have occurred across the NIH. Because of the long-term nature of research, the full impact of these terminations is largely in the future, but that is not to say that the impacts are hard to anticipate. NIH lost institute directors, experienced PhD scientists who serve as program officers and scientific review officers, and business-trained grants management specialists. These individuals are key to the careful stewardship of 80% of the NIH appropriation that is distributed to universities, academic medical centers, and research institutes across the country. About 11% of the NIH appropriation supports the NIH intramural research program, including at the NIH Clinical Center, the largest research hospital in the world. Staff involved in procurement and contracting have been fired. Support staff for other areas at the Clinical Center have been dismissed. Physician scientists at the Clinical Center have resigned out of frustration. The consequences of these terminations are not always evident, as information from inside NIH has not been forthcoming. However, I can summarize the consequences of these terminations in one word: delay. NIH has been slow in making grants. Most of these grants don't require review by anyone other than government employees, and they are normally paid out in a timely way. Yet NIH is behind last year by $2.75 billion. These grants touch on every aspect, essentially every aspect of health that NIH covers. This is not due to the actions, or rather the lack of action, by the hardworking NIH career staff. However, NIH has its work cut out for it to get all the appropriated funds committed before the end of the fiscal year. Termination of grants management specialists may make it even harder and will affect all aspects of the NIH mission. The most time-sensitive component of NIH are clinical trials. This time sensitivity has two components. First, at the trial level, for some trials, even delay of a month or two has the potential to invalidate the entire trial. Participants often have contact with trial staff at scheduled intervals, and if these schedules are interrupted, then the results from different participants in the trial may not be comparable. More heartbreaking are trials on cancer patients who have exhausted all other treatments before enrolling in an NIH clinical trial. For many years, Dr. Steven Rosenberg at the National Cancer Institute has been developing methods for taking a patient's own blood, immune cells, and teaching them to attack the patient's tumor. Early on in the NIH terminations, I heard from a staff member who was terminated supposedly because of, quote, inadequate performance, despite a perfect performance review. She warned me that the blood products team would be short-staffed and would not be able to manage the workload. Sadly, she was correct. News stories have now identified that trials are being delayed for this reason. A delay of a month or two might not seem like a lot, but many of the patients in these trials don't have many months left. And these treatments represent a chance for a strong, favorable outcome for individual patients and an opportunity for researchers to learn how to make these treatments work better in the future. I honestly cannot imagine how frustrating it must be for these patients and their loved ones. The number of research subjects and patients at the clinical center is down, apparently by 30% or more. This prevents patients from receiving care, slows research, and is a colossal waste of resources for the world's greatest research hospital. That this is being done in the name of efficiency would make George Orwell blush. Thank you.
Thank you. And thank you all very much. We've just been joined by Senator Durbin, my leader in the Senate Judiciary Committee and wonderful member of the Senate for a long time. He says he's going to retire, but we haven't voted on that yet. Senator Durbin, we've just heard pretty depressing stories from 5 very hardworking people about the impact of these sudden and senseless cuts.
Thanks for calling attention to this issue. I was in the hearing yesterday for the markup for the Department of Health and Human Services and heard once again that we were just cutting out fraud and waste. Can you tell me, any of you, from your own personal experience, what the typical outcome is for a researcher who has a grant discontinued? What happens next?
I think the short answer is we don't really know, and it depends. I think in some cases, they're able to find resources from their home institution for a while. In other cases, those resources aren't available, and the project is discontinued and cannot easily be restarted. There have been so many terminations of grants, including hundreds that were just revealed yesterday or the day before, that it's an ongoing process to try to keep track of everything that's happening.
Yeah, I just can add, I mean, I think that depending where one is in one's career, it might mean that you give up on science, that you give up on research, and that you go into another sector. We've also seen reports of people going to other countries who can get research funding elsewhere. In public health research, that doesn't really work because everybody's really depending on us here in the US in terms of world leaders in a lot of the conditions that only the US is really, investigating, whether it's Ebola or Zika or something like that. So I think early career people may be moving into something else. More senior or mid-level researchers are losing their staff, and it's a waste of government money in terms of the investments and a loss of future return on investment in terms of the patents and the lives saved.
Tell me about the argument that I hear from them that the United States is doing more than its fair share of research. It's time for other countries to step up. What about that argument?
We have an incredible legacy of leadership, invention, discovery, and prosperity because of the research and the science infrastructure. I think my colleague from NIH could probably say more, but I think that from the CDC's perspective, people around the world come to the CDC to learn how to do things and then take them back to their own countries and make them healthier and safer. So I think we all become healthier and safer by there being more capacity in research and of course, in prevention as well.
Let's speak for a minute, if I can ask you, on the issue of lead poisoning. Congress funded the Childhood Lead Poisoning Prevention Program at CDC with $51 million, and with federal funds, the Chicago Health Department reduced the rate of children with elevated blood levels from 70% in 1996 to 2% today. The entire division working to prevent kids from being poisoned by lead was fired. Given how much progress we've made to address child lead poisoning, what do you think is the impact of eliminating this office?
This is really devastating because when a child is exposed to high lead levels,
And there's no safe level.
no safe level, but when a child is exposed to lead, they lose intellectual capacity. They don't get it back. So it's really irreversible and devastating. And as we spoke earlier, you know, an outbreak in Milwaukee schools, a
Right.
call for help from the CDC, the program is gone. There's no one to respond to it. And for those children that are exposed and the states that depend on the expertise, it's really tragic.
I asked Secretary Kennedy yesterday what was the #1 preventable cause of death in America today, as he's spoken about how bad our health was generally. He couldn't come up with the answer, and the answer is tobacco. It's an issue that I've been working on for a long time, and it just strikes me as this is a gift to big tobacco to decimate the FDA Center for Tobacco Products, firing its director and most of its employees. How does the CDC's Office of Smoking and Public Health prevent tobacco addiction for
Hey,
kids
Tammy.
and help adults
Good to see
quit?
you.
Yeah, thank you so
you.
much for your support
Yeah,
over the
yeah, thanks.
decades. The Office of Smoking and Health at CDC worked very closely with the FDA and was supporting states in the quit line, in the tips from former smokers, in the ability to link policy with prevention, and is estimated to have saved over 100,000 lives through the simple quit lines that we had for, through the congressional support.
10 years ago, when I went to see a great American named Francis Collins at NIH, and I said to him, I'm old enough to remember when 3 members of Congress came together and had a goal of doubling the NIH budget, which they did. It was nothing short of a political miracle, bipartisan effort. Included John Porter, a congressman from the Republican congressman from my state of Illinois. And I asked Dr. Collins, I said, I can't double it. I don't think that's realistic. It's about 40 billion now. What can I do? He said, give us 5% real growth, consistent, predictable, real growth, and good things are going to happen. And he kind of felt, and I felt as well, it would create a bandwagon effect. People would be so impressed with how much we discovered. And I set out to do it. Patty Murray was my partner in that for obvious reasons. She's one of the best. But in addition, Roy Blunt, conservative Republican, state of Missouri, led the way in the Appropriations Committee, and Lamar Alexander from the state of Tennessee. The 4 of us in the span of 10 years went from 40 to $60 billion at NIH. What's going to happen now with the proposed budget is to wipe out the whole 10-year progress, 10-year addition. We'll be back to the 40 billion figure. And I think the impact on researchers, even on those who would go to school to prepare for that kind of life, has got to be devastating. And the point I made yesterday to Senator Kennedy, it isn't just the loss of research, it's the loss of hope. I talked about a friend of mine named Wallach, who has ALS, and his wife, Sandra Bravaya. And I said to them, this research is more than a possible cure for his ALS. It is hope that keeps him hanging on for another day or another week. They contacted me last night and said, you're spot on. It's exactly what it is. I think about that. So it's not just the loss of research. It's the message that we're sending about hope as to whether or not a cure can be found. What a heartbreaking development. Hard to imagine. I don't think Americans were voting for that in the last election. Thank you, Peter.
Thank you.
Senator,
Did you?
can I respond? I had not heard the we're doing more than our share of research. That it's like saying, you know, we're getting more than our share of economic growth. It makes no sense at all. It's not a cost, it's an investment. The return on that investment is, by lots of analyses, on the about 2.5-fold for every dollar that's invested. So there was just an article in Forbes the day or so before yesterday that the cuts that were proposed would cost the country $10 billion a year after subtracting out the costs of NIH. With regard to the comment that I completely agree with from Dr. Shukat, the other countries are eager to step into this space. China has been working very actively to try to become the world leaders in biomedical research, and we're basically threatening to just walk off the field and say, fine with us, which is nuts. But other countries as well. Canada is stepping in, seeing the opportunity. I just saw an article in the Irish Times. I love the Irish Times. It's a great paper. And they also, their headline writers are very direct. And the headline is, "The idiot wind now howling through the U.S. offers Ireland a transformative windfall." So,
Idiot wind.
yeah, and transformative windfall. I mean, NIH research, the biotechnology industry, which everybody takes for granted, that was created because of NIH-funded research. And we've been the world leaders in that for a long time. The industry was born here, it was developed here, it's been tremendously important in developing new drugs and new treatments, but it's also just been responsible for, I don't know the numbers, but hundreds of thousands, millions of jobs. Why would you back away from that? It's crazy.
We've been joined by our leader in these panels, Senator Tammy Baldwin of Wisconsin. Thank you, Senator.
Well, thank you. And Senator Welch, I want to give you a lot of credit for the last 2 days of hearings highlighting this critical issue of what these mass layoffs mean for U.S. citizens today, but also their implications for the future. And the ramifications are so vast, we had to have 2 days of hearings. So thank you for leading on this. I have questions about the Administration for Community Living, SAMHSA, NIH, but I think I'll give you the sort of glimpse of where I want to end, which is, we're working on 2026 fiscal year budgets. We have the skinny budget. But I've been so concerned that the dismantling that's happening may lead to irreparable damage. And so I'm going to end, not start, but end with the question of where would you have us look carefully to try to prevent the type of irreparable damage that we'll never be able to rebuild. And it might be in all of these areas. But I'm going to start with the Administration for Community Living, because it's really the only federal agency dedicated to providing tens of millions of seniors, older adults, people with disabilities, and caregivers with the support to help people live independently in their communities. It oversees Meals on Wheels and aging and disability resource centers. My career in public service was shaped by my own experience, being raised by my grandparents, how lucky I was to have them when I needed them, but also later serving as my grandmother's caregiver. There are 53 million family caregivers in this country, and they deserve support from Health and Human Services. Firing about half of the staff at the Administration for Community Living and proposing to eliminate the agency will jeopardize support for these caregivers and the loved ones that they care for. So, Professor Barkoff, what will the elimination of the Administration for Community Living mean for specifically the 53 million family caregivers that, come forward to care for the people they love with not a lot of supports?
Senator Baldwin, thank you so much for your longstanding support of ACL and for our programs and for that important question. ACL, as you say, is one of the only federal agencies that focuses on family caregivers who are the backbone of our long-term care system because we do not really have a full system. And if we cut these services, many of the services that are proposed to be eliminated or reduced are literally the life-saving supports. Think about respite. It is mind-blowing that one of the proposals is to eliminate respite. That is the type of service where if you are taking care of your mother with Alzheimer's and need to bring her somewhere for the day so you can go to work, that means 53 million people literally leaving the workforce. We have $600 billion in lost economic value in our country because of services like that. There are so many things that are happening right now with the loss of half of the staff. As I mentioned earlier, literally funding that you passed in March did not go out. It was delayed, maybe a lawyer might say impounded, and the only reason that it was released was because of advocacy. And what we saw in that short period of time was that aging providers had to start reducing services. We're incredibly concerned about the impact that it is going to put more on family caregivers. And for families that are already stretched thin, it will place people at serious risk of having to go into nursing homes at much higher costs, particularly to Medicaid. And if you add that in with what is literally happening today on the other side of the Capitol, the most draconian cuts to Medicaid, which is the lifeline for older adults and people with disabilities to stay in their own home, I'm incredibly concerned what is ahead for family caregivers.
Thank you. States rely on SAMHSA for support and resources and best practices to tackle the opioid epidemic and have successful mental health programs. According to the Wisconsin Department of Health Services, since the terminations and cuts at SAMHSA began in April, the state has lost access to resources and technical assistance that would normally be provided to states. Last week, CDC released data from 2024 showing that drug overdose deaths fell last year by 30,000 nationally, a 27% reduction over the prior year. And Wisconsin was one of the states that saw an over 35% decline. This is good news, but 80,000 nationwide deaths from drug overdoses is still far too many. Now is the time to build on our prior progress, not slow it down. So, Ms. Dutta, how will the firings of SAMHSA staff and the proposal to shift SAMHSA into a new agency that we know very little about harm the progress that we've been seeing in reducing overdose deaths?
Thank you so much for your question, Senator Baldwin. So there's kind of two pieces of your question. One is around the cuts to programs that support the work that you talked about, particularly the opioid use epidemic and the 27% lower level of deaths that we saw in this past year, which is a fairly phenomenal finding for a public health system to be able to achieve. So there's that piece, and then there's this transition of SAMHSA into this kind of larger structure of the Administration for a Healthy America. I think the first piece around the budget piece, and if I may, I will offer that we have not really adequately funded our mental health and substance use system pretty much ever. So right now what we're seeing is the biggest investment that we've ever had in our behavioral health system between SAMHSA and a whole host of other agencies, the resources that we get from Medicaid that go towards mental health and substance use treatment. But specifically for SAMHSA, if these programs are cut, you squeeze the balloon, people will have to go somewhere to get these services. We already know that not enough people who have needs, who have mental health diagnoses or substance use diagnoses are not receiving care, and there's a whole host of reasons. It's related to lack of health insurance, it's related to stigma, it's related to a lack of providers. If these programs are cut, states will have to look to other places, or ultimately people will not have access to the life-saving care they need. In some cases, the block grants, states will have to rely quite heavily on their block grants, which I would surmise are already going to be tapped quite heavily if Medicaid cuts come through. States will have to go somewhere to fund these services. Or the worst case scenario is that people just will not get the care that they need, and then we kind of know what will happen there. So that's the first piece on the budget piece. The second piece is around the integration of SAMHSA into this new AHA structure. I think there's still not a lot known about what that integration will look like, but mental health and substance use issues have been so highly stigmatized for so long that having them sort of subsumed in this larger structure without the ability for the government to really be able to focus and dedicate funds and resources and have dedicated subject matter experts on that work, that will just have us moving backwards in time. We're at a point now where you have the NFL talking about suicide and depression. It's sort of where the country was with cancer over the past 40 or 50 years, where now people will talk about cancer, whereas before it was something that was very quiet. If you look at our suicide crisis, a lot of people were not willing to get care when they needed it because of the stigma. And if we move our behavioral health investments and focus kind of into the shadows of this larger organization, we will be taking the risk of moving back in time to a time and place when people were not comfortable reaching out for care. And that also has an impact on the workforce. If people feel like that this kind of body of work is not reimbursed, is not respected, et cetera, we already have a workforce challenge with regards to mental health and substance use disorders, and that could be that much more exacerbated. So
You've queued up my next question on SAMHSA so beautifully in that, talking about bringing back some of these things back into the shadows. And I was proud to work with colleagues to create the 988 suicide prevention hotline. It's also critical that people get help from somebody who understands what they're going through. And so as we know, we have a special screening question to identify veterans of military service to get specialized behavioral health care through the VA should they choose. We've also, on a bipartisan basis, funded a pilot program for LGBTQ youth, where we know there's staggering rates of suicidal ideation, and suicide attempts. In other agencies, we have special mental health services for farmers and ranchers and farm workers, where there's a strikingly high rate of suicide. But I'm deeply concerned about what the elimination of a specialized service for LGBTQ youth will mean. I had a chance to speak with Secretary Kennedy about that. Their excuse is basically, we don't want to divide Americans. I want to lower the suicide rate. And anyways, I wonder, Ms. Dutta, what you can tell me about why specialized services, culturally congruent services provided by 988 are critical to suicide prevention.
thank you so much for that question and for your advocacy in bringing about the 988 Lifeline. So there's an interesting sort of challenge here where if you build it, people don't always come, right? So if you build, you can have the best, shiniest thing, and if people don't see themselves or see an ability for them to receive what they need from that shiny, beautiful thing, then they will move on past it. And we see that around behavioral health services across the boards, and which is why culturally appropriate care is so important, both on the mental health side and the substance use treatment side. I think because of what you said around the fact that we know that the LGBTQI community is at higher risk for a whole host of behavioral health issues, which SAMHSA has been able to track over time through our national survey on drug use and health. But particularly when you look at suicide and risk for suicide, planning for suicide, those types of things, the LGBTQI population is at extraordinary high risk, particularly young LGBTQ individuals. Moving away from having the 988, the specific dialed 3 call line for that community, would likely not only mean that you don't have the culturally appropriate services for that community, where SAMHSA has worked with community providers and has an arrangement with the Trevor Project to help support those dedicated crisis referral services, but you also have sort of the messaging that the federal government doesn't feel like this is an important service anymore. And by asking those young people to dial the kind of general 988 line, they might not feel comfortable or welcomed or make assumptions about what the staff will be able to do. So I think there's sort of two components there. You're removing access to culturally appropriate care for a community that is at high risk, but you're also messaging about the importance of that sort of really specific type of intervention, which I think both of those things would be really tragic for that community of young people who continue to really struggle with their behavioral health issues.
Thank you. One question about the NIH, and then if you'll indulge me with where are you most focused on in terms of irreparable harm that could happen before we're even voting on the fiscal year 2026 budget. But I said to Secretary Kennedy yesterday when he came before our appropriations subcommittee that Congress has spent nearly 100 years building up the world's premier biomedical research agency to develop state-of-the-art treatments, cures, and in just 100 days, this administration seems to be tearing it all down. You may have heard the figures earlier in this hearing, but we're at a point where we've spent about $3 billion less in funding grants this year than we did last year, and more than 3,200 fewer grants compared to, at this point in time, last year. Secretary Kennedy has claimed that no working scientists have been fired, but it is just not true. And the results for the American people are catastrophic, especially for those who are directly impacted by the search for treatments and cures. Mr. Berg, what do firings and delays in funding at NIH mean long-term for the biomedical research enterprise? And then, as a follow-up, will this be so damaged it'll be impossible to build back? Or what would you direct us to look at right now and in the future?
The damage that's being done is, as you say, just literally unbelievable to me. When the Trump administration came in, I expected to get into discussions about the best way to reform NIH and to make it the best it can be. And it's not. I think it's was a wonderfully high-performing agency, talented people, absolutely committed to a noble mission. But instead, it's just been, breaking stuff and just everything they can see, it seems, everything they can attack, they're doing that. I don't know. It's that the attacks have been so broad and the consequences are so substantial. I don't really know how it's going to play out. Universities are, the intramural program, the one grain of truth, I think, in Senator and Secretary Kennedy's comment, they originally fired a bunch of tenure-track investigators in the NIH intramural program, and as far as I know, they've all been reinstated, although there are some in the National Institute of Neurology who were fired because of a personnel HR coding error that they somehow put a number into their system and they thought they were firing one group of people and it turned out they were firing 11 senior scientists within NINDS. And I think that's been reversed, but I'm not sure it's been formally completely reversed, so they're sort of in Never Never Land, which is a place where a lot of NIH seems to be living right now, where they just don't know what's happening and what to do about it. But there have been staff scientists fired. There have been program officers and scientific review administrators who are they practicing scientists? Are they doing experiments in the lab? Not anymore, but they're PhD-trained people who are very much part of the effort. The impact at universities of everything that's going on, the indirect cost cut threats, grant terminations, not paying things through the payment management system, on down the list is just devastating. Universities are scared to death and are keeping their heads down because they don't want to be the next Columbia or the next Harvard or the next Northwestern or whatever, but sadly, the people I've learned the most from in this are historians who study authoritarian regimes, who point out that this has happened lots of times and it goes the same way. And if you keep your head down, you might not be third or fourth, but you'll be 15th or 20th. So it's not really a very good strategy. And that's, it's unfortunate. I mean, I absolutely understand what's going on and why universities are acting the way they are, but it's not a survival strategy. It's just a short-term strategy to avoid real pain. The long-term consequences, I think Dr. Shuka touched at it. The biggest concern that I have is the future of the enterprise. I mean, the enterprise, which has been so productive and so good to so many people, is being dismantled. And honestly, if I were a young scientist thinking about going into a biomedical research career, I don't know what I would do now. I might say, engineering looks pretty good and I won't have to depend on NIH for funding to do what I might be able to do, or maybe I'll go into industry. Those are all perfectly noble things to do, but you can't do it without the special role that NIH plays. If I may, can I tell sort of two stories, one from my past and one from the present? So when I was a young department chair at Hopkins Medical School in the 90s, and the AIDS epidemic was ravaging the country. It started off in the gay male community in San Francisco and LA and New York, and then it spread through larger communities, through blood transfusions and into the heterosexual community. And when I was at Hopkins, and this is probably 1993, 1994, I was sitting in the Hopkins boardroom with discussions with all the department leaders, all the medical school leadership, saying, where are we going to treat the non-AIDS patients? We're going to run out of beds. We're just not going to have anywhere to treat them. Call out to CDC. The weekly report, the MMWR, was incredibly valuable in this whole process. So in 1996, the report showed that HIV infection was the leading cause of death among persons 25 to 44 in the country, ahead of cancer, ahead of unintentional injury, ahead of heart disease, ahead of suicide, ahead of homicide. It was terrifying. I mean, I was in my early 30s, I was in this room and I was just like, wow. And then NIH-funded research and other research in the next year or two developed combination chemotherapy, antiretroviral therapy, and I remember, reading the paper and going, oh, if this is real, this is amazing, because the drug resistance problem looks like it had been defeated. And within a couple of years, HIV was another chronic disease. Magic Johnson, still here. Lots of people still here. I had friends who lived in the gay community, and they would say, today was an amazing day. I read the newspaper, and there was nobody I recognized in the obituary section. Wow. I mean, it was just awful. So that's what it can do. We were in deep trouble. This was, because the fatality rate was more or less 1 per case. It looked like, it wasn't nearly as bad as COVID, but it looked like it was just going to wipe out a huge swath of the country, and then it wasn't. It was sort of like in my parents' age with polio. Yep. Iron lungs and huge hospitals, and all of a sudden vaccines, and oh, never mind. The most recent thing, the story that I've been focused on in January 30th, FDA approved a new pain medication, which got a lot of press because it's a non-opioid. It works by a completely different mechanism, and there's basically no sensible mechanism that anybody can think of that it could lead to addiction. And this was a big deal. So I was curious about how did this happen? What is it? And it turns out that the drug targets what are called sodium channels, which are key components of our nervous system. and which had been discovered, their existence had been sort of hypothesized in the 1940s in England, leading to a Nobel Prize. And then researchers, actually a person who was a postdoc at NIH and learned all the techniques, went to the University of Washington and actually figured out a way to identify the sodium channels, the proteins themselves. And then for the next 20 years, scientists in academia and industry characterized, it turns out we have 11 different sodium channels, some of them in our brains, some of them in our muscles, and there are 2 that are involved in pain sensation. Now, the challenge is if you have a drug that inhibits one of the sodium channels, there are compounds which inhibit the channels in the brain, in the central nervous system. Scorpion toxin is one of them. So evolution has discovered this is a really good way if you want to kill the person, kill the animal that is a threat to you. So you don't want to do that. But because it was so effective and because of the Human Genome Project and so on, there are 2 families, one in Pakistan and one in China, that had mutations in one of the sodium channels. And these families, just the people in this family who had that mutation, didn't feel pain, which is actually a very bad thing because you burn yourself and all sorts of things. But it sort of proved that if you could inhibit this, it could have a big effect. So almost every drug company tried to target this, and they all failed. They failed in the lab, they failed in the clinic, and then one company persisted. They failed in a clinical trial, and they kept going. They had good technology, which they had developed, and they kept pushing on, and that was the compound that was reported. So it turns out that the clinical trials were in patients who had bunion surgery or tummy tuck surgery. So post-surgical, annoying but not life-threatening pain. They got this drug compared to placebo, and it worked. And this was basic research followed by applied research with industry and NIH-funded scientists working together. The biotechnology or pharmaceutical companies stepped in and took huge risks to develop this. So the compound that they found inhibits this one channel 55,000 times more effectively than any of the other ones. So it's really remarkably safe. So other than being a potential new pain medication and finally addressing the demand side of the opioid crisis as opposed to the supply side, it's not a big deal. It's a big deal. So that's how it can work. And why are we backing away from that?
Yeah.
So, thank you.
I think when I think of ARC and the work that ARC has done over the last 30, 40 years, you'd be hard-pressed to find any point in healthcare that hasn't been improved by the work at ARC, whether it's the doctor-patient interaction, whether it's enhancing medical records, and now with wonderful research on AI and other computational tools. The way that issues like emergency department boarding are being researched, or how ambulances can be more effective in those critical moments when they're taking someone that might have had a heart attack. There's research throughout ARC that impacts all of our lives. And when I think of ARC and what might be lost, I think of well, there's many components, but 2 certainly come to mind. And I think of a center that creates the tools doctors use. The Center for Evidence and Practice Improvement takes data and it synthesizes it in a way that doctors then can use in their healthcare settings. It plays a critical role in informing practice. And that knowledge is generated by the research office out of ARC, the Office of Extramural Research and Education and Priority Populations funds researchers that my colleagues are talking about across the United States. And that research is critical to funding this information. And when that's lost, we lose the data for the insights that we need to improve our healthcare systems, their performance. I mean, if you don't measure it, you can't fix it. And so that's critical. And ARC researchers work in the real world. And so they're in the moment seeing what works and enhancing it. And when we lose that real world science that leads to those clinical innovations, we lose the ability to enhance. We lose opportunities to bring in the patient experience. You know, patients, we are all part of healthcare. And when we lose that research, we lose bringing in that patient voice, which ultimately makes healthcare safer and more effective. And as my other colleagues here have mentioned, when we don't fund these scholars, we lose decades of knowledge and teams of knowledge. I spoke to a researcher last week that is now working in ambulances, in examining those critical moments. She's leading a huge team that has researched over the last decades enormous aspects of healthcare. She began her research with a graduate student dissertation grant and is now one of the leading scholars in the US and recognized world over. We would lose that knowledge that's generated in our country to enhance our healthcare. And I think all of these issues are deeply troubling and intersect with other aspects my colleagues have mentioned.
I want to thank everybody. You know, what we're hearing is pretty straightforward. Less service, less research, fewer cures, less ability to put Humpty Dumpty back together again, and most importantly, less hope. You know, people depend on this. People depend on having the call answered when they have this crisis at their local school. It is just astonishing. And the lack of hope is what so bothers me. You know, an optimistic country doesn't deny the challenges it faces. An optimistic country addresses them, and in the process, you make a stronger country and you create a stronger economy because you deal with what is before you. And you've all done that. So you all are builders. We've got a different team in charge at the moment, Doge, in their ilk. But you've got friends and allies here in Congress that want to honor the work that you've done and make certain that we'll get through this. And folks who follow in your footsteps will continue to do the work that for so long you've done so well and so beneficially to the people of this country. So thank you, one and all.
Oh, thank you, Senator.